Good evening, everyone. My name is Daniel Morin. I'm an electrophysiologist at the Ochsner Medical Center in New Orleans, Louisiana. And I'm also senior consulting editor for Circulation, Arrhythmia, and Electrophysiology. On behalf of our editor-in-chief, Dr. Paul Wang, I'd like to welcome you to this month's Circulation A&E webinar on ventricular arrhythmias and sudden death. We've done a number of these webinars, and they've all been excellent. I'm sure that tonight will be no exception. To mention something up front, participants who are dialing in or on Zoom and are not panelists will be muted. However, we do want to encourage participation. So please use the Q&A function at the bottom of your Zoom menu, Zoom window, so that we can definitely get to your questions, which will happen after our presentation. At this time, I'd like to turn it over to two of the leaders of our ventricular arrhythmias and sudden cardiac arrest advisory group, Betsy Kaufman and Pasquale Santangeli. Betsy and Pasquale, please take it away.
Thank you, Daniel. This is Pasquale Santangeli from the University of Pennsylvania. With me, I have my co-moderator, Dr. Kaufman from Metro Health. We have the pleasure tonight of introducing a very important paper that has a lot of clinical implications by Dr. Greg Mellor, who's a consultant at the Europe Papworth Hospital in Cambridge, in the UK. And thank you for being with us tonight. And a panel of expert commentators that will be Dr. Parikh, Victoria Parikh from Stanford University, Dr. Joshua Cooper from Temple University, and my colleague, Dr. Rajat from the University of Pennsylvania. The webinar will be composed of two sections. The first part will be a presentation of the paper by Dr. Mellor, and then will be open for discussion together with the panelists. So, Dr. Mellor, please.
Thank you very much. I will just grab my slides. Hopefully you can see these now. Thank you very much for this invitation and opportunity to present on behalf of myself and my co-authors our paper, Familial Evaluation in Idiopathic Ventricular Fibrillation, focusing on the diagnostic yield and the significance of J-wave syndromes. So as we all know, cardiac arrests are very common, and the vast majority of these are due to coronary artery disease, either acute ischemia or the long-term consequence of prior infarction. But as this French study showed of consecutive cardiac arrest survivors, around 25% of people will have a non-ischemic etiology. The majority of those will be cardiomyopathies, with a small number of channelopathies also diagnosed. Both of these diagnoses will commonly have a genetic etiology, and identification of such diagnosis will trigger family cardiac screening, both with clinical assessment and potentially genetic testing. Those patients who don't receive a specific diagnosis after surviving a cardiac arrest receive the label of idiopathic VF. Although it must be noted that there is no consensus on what investigation should be performed before that label is administered. And in this particular study, the degree of investigation of these idiopathic VF patients was very heterogeneous. Further focusing on these apparently unexplained cardiac arrests, much of our knowledge in this field comes from a large registry, the CASPER registry from Canada. This recruits patients who are survivors of cardiac arrests, who have normal coronary arteries, a normal resting 12-lead ECG, and a normal left ventricle on echocardiography. And this paper shows that systematic investigation of such patients will reveal a specific diagnosis in around 40%. And again, you'll see the pie chart on the right of the diagnoses that many of these have a genetic etiology and again would trigger family screening. The remainder of those patients remain unexplained. However, further evaluation with genetic testing in this cohort, particularly of patients with no clinically identifiable phenotype, still identifies a pathogenic or likely pathogenic variant in around 10% of patients. And you'll see here that the genes mentioned are those associated with established inherited arrhythmia syndromes and cardiomyopathy, particularly Brugada syndrome, non-QT syndrome, and arrhythmogenic cardiomyopathy. Furthermore, long-term follow-up of these patients will also reveal a specific diagnosis that wasn't identifiable at the time of cardiac arrest. This is a study from Utrecht in Holland of around 100 initially idiopathic VF patients, followed over around 10 years, and 20% of those patients developed a clinical phenotype. And again, you'll see that many of these are heritable phenotypes. And this combination of observations led to the hypothesis for this study that familial screening may reveal a heritable diagnosis in first-degree relatives that was not apparent in the idiopathic VF proband or survivor. This was a multi-center observational study carried out at 6 centers across Europe and in Canada. And the inclusion criteria for the study was twofold. Firstly, we focused on the VF survivors themselves. We asked each institution to identify patients with unexplained cardiac arrest, so that is with normal coronary arteries, echocardiogram, and ECG, but then also had a very stringent inclusion criteria for additional clinical assessment. All VF survivors had to have a minimum assessment, including a resting ECG, preferably with high RV leads, with coronary imaging, structural imaging with echo and or MRI, an exercise ECG, and a sodium channel blocker provocation. And all of those tests had to be negative. And we felt that that combination would reliably, or as well as we could, exclude the many heritable diagnoses listed in the table here. After applying this stringent criteria, we had 271 VF survivors with a label of idiopathic VF. We included in our study those patients with so-called short coupled ventricular fibrillation and early repolarization, as we felt that these represented a spectrum of idiopathic VF. 175 of these 271 patients had not had any relatives assessed, and so they were excluded. Because the second part of the exclusion criteria was that at least one family member had to have been assessed with a minimum of a 12-lead ECG. This led to 96 families and 201 relatives from those families. In terms of the cardiac arrest survivors themselves, there was a mean age of 39, about a 50-50 split between men and women, and the majority were of white European heritage. The most common circumstance of cardiac arrest was awake but at rest, with a minority on exercise and sleeping. Prior syncope, remote to the cardiac arrest, and a family history of other sudden death were relatively rare. In addition to the minimum clinical criteria, additional investigations quite commonly included an MRI. Genetic testing was performed in around 3/4 of patients. This was not pre-specified and was performed at the discretion of the treating physician. Around half of patients had a signal average ECG, and a third had an epinephrine provocation as well as an exercise test. Again, no firm diagnoses were made in any of these, barring genetics, which we'll come to discuss later on. In terms of the relatives, as I said, we had 201 first-degree relatives from 96 families. And the icons here, there's one icon for each family assessed. The number on each icon is the number of relatives within that family who were assessed. And you can see that ranges from 1 up to 5 relatives. The average age was 37 and a slight predominance of men compared to women, a relatively even split between offspring, siblings, and parents of the cardiac arrest survivor. And again, symptoms, particularly syncope in these patients, was rare, as was a family history of sudden death other than the proband in question. All patients had a 12-lead ECG as per the inclusion criteria for the study. The majority also had an echocardiogram, an exercise ECG, with MRI and sodium channel blocker tests being performed less commonly. The results of these family assessments were that the vast majority had no identifiable diagnosis made. So in 92 families and 196 individuals, no diagnosis was made after the combination of tests listed above. In 3 families, a relative, in each case the parent of the cardiac arrest survivor, had a positive sodium channel blocker test and so was diagnosed with Brugada syndrome. In a single family, the survivor themselves was identified to carry the DPP6 risk haplotype, and screening of 5 family members identified 2 other relatives to carry that same genetic variant. For those unfamiliar, DPP6 is a gene that encodes a protein that regulates both the cell surface expression and function of potassium channels, particularly those implicated in the transient outward current in his Purkinje cells. It is the only well-established genetic cause of familial idiopathic ventricular fibrillation. This is the pedigree of the family in question. So you can see the male cardiac arrest survivor indicated with the arrow, and a brother and his daughter were both identified as DPP6 carriers. His daughter underwent a primary prevention subcutaneous ICD implant. The reason for this decision was that studies have shown that the penetrance of this variant, i.e. the risk of cardiac arrest, approaches 50% by the age of 60. However, applying these results, and particularly the usefulness of DPP6 testing to the general population, is limited because this is a founder mutation found almost exclusively in the Netherlands and concentrated in this area in the center of the country. And indeed, our patient came from our Utrecht cohort, which is situated right in that high frequency area in the center of the Netherlands. As mentioned, the remaining 3 families all had a parent diagnosed with Brugada syndrome based on a sodium channel test. This pedigree, in fact, was the first family that triggered this particular study. This is when I was a research fellow at St. George's with Professor Baer. We had a 21-year-old male, idiopathic VF with a negative Ashmolean test that's shown on the left side of the screen. His father had a type 2 Brugada ECG pattern on his resting ECG and went on to have a clearly positive Ashmolean provocation test with a type 1 ECG seen both in the standard and high lead positions. The father was asymptomatic. He was managed with lifestyle medications, did not receive an ICD, and has been well since. The stories in the other 3 families were very similar. In addition to looking at firm diagnosis, we also analysed the frequency of the early repolarization ECG pattern, both in our IVF survivors and their relatives. Infralateral early repolarization has been associated with an increased risk of sudden death, particularly associated with otherwise idiopathic VF, but also in a number of other clinical circumstances. 16% of our idiopathic VF survivors had an ER pattern on a single ECG around the time of their arrest. Of those 16 families, 25% had at least one relative who also had the ER pattern on their ECG. And this was significantly higher than relatives of those probands who did not have an early repolarization pattern themselves, with fewer than 10% of those families having one relative with ER. The clinical significance of this, however, remains unclear. We do know that ER is a heritable phenotype, although the specific genetics remain unidentified at present. And what's also known is that while the relative risk of sudden cardiac arrest is increased in the general population in those with ER, particularly in middle-aged individuals, the absolute risk of cardiac arrest remains low, and there are no recommendations for prophylactic ICD or indeed any medical therapy for these patients. So the conclusions of our study was that regarding idiopathic ventricular fibrillation, the yield of family screening is low, and detailed assessment of the proband should be the focus. There does seem to be a role of J-waves in families with idiopathic VF, although this needs further research and little clinical work. It has little clinical significance for families at this stage. So thank you very much. I'd like to acknowledge all of my co-authors from the various centres, as I said, across Europe and Canada. And at this point, turn things over to the panel for any questions. Thank you very much.
Thank you very much. That was very clear, and I guess there are a number of questions in my mind that I'm going to ask you and the panelists to think about. One is, I'm impressed that it may in fact be worthwhile doing sodium channel block provocation in family members when the proband has come up with no phenotype. Do you think that it should be limited to those with a type 2 pattern to start with, or and have a focus, or do you think that this should be done on a wider basis?
I think that's an excellent question. There is a lot of controversy and disagreement around the significance of positive sodium channel blocker tests in asymptomatic individuals. And this is driven by the fact that there's a concern about a high false positive rates. In studies, that 5% of asymptomatic individuals with no history of sudden unexplained death in their family may have a positive test. And in fact, in one study of patients with AVNRT, around 20% of those patients had a positive Ashmolean test. So the clinical significance of a positive Ashmolean test on its own is difficult to ascertain. We also know that the long-term prognosis of those patients diagnosed with Brugada based on just the positive Ashmolean is generally very good and no intervention is required. So given those two facts, I think widespread use of sodium channel blocker provocation in asymptomatic relatives may cause more problems than it solves. So I would reserve it for patients where there is a particular concern, or as you mentioned, they have a highly suggestive resting ECG.
Makes sense. Any of the panelists want to comment?
I had a question about the ECG component of the participation and whether a single ECG suffices, or given the variability that ECGs can demonstrate at different periods of time, whether there would be any incremental yield of having different ECGs separated by certain weeks or months.
Yeah, again, a great point, and you're quite right in the fact that many of these phenotypes that we're talking about can be very variable. So Brugada syndrome is classic for that. Also long QT or QT interval can appear very normal, particularly at lower heart rates. So multiple ECGs I think are useful. From a practical point of view, in family members coming for a single assessment, I think it can be difficult to do. And that's why we tend to rely more on the provocation tests. We felt that the combination of assessment we had for our survivors with the use of exercise and sodium channel provocation hopefully got around some of that ECG variability. But certainly there could be diagnoses missed. As that follow-up study showed, over time, things can change.
Dr. Mellor, great presentation. Congratulations on your paper. I have a question related to the early repolarization pattern. Obviously, you detected it more commonly in those families where the proband had ERP, early repolarization pattern. And I noticed that MRI seemed, or cardiac MRI seemed to be underutilized overall in your study, especially in the family screening. I think only about 10 to 11%. And I wonder, I'd love to get your thoughts in terms of should families where the ERP pattern is present, do you feel there's a role for cardiac MRI, especially in those individuals, especially given our understanding of fractionated potentials that we are now becoming more aware of in other repolarization syndromes like Brugada?
So yeah, once again, a great point. I think in terms of the ER pattern, I think we still don't really have good understanding and agreement about what that actually represents as a phenotype in the heart. Whether this is genuine early repolarization or whether it is a form of delayed depolarization and fractionation. And I don't think the 12-lead ECG is ever going to be enough to resolve that. There has been some nice work by Michel Hasseguer looking at different phenotypes in terms of in-depth intracardiac evaluation of these patients to try and differentiate different subtypes. I'm not aware that MRI would be sufficiently or have a sufficient resolution to identify structural changes in the setting of ER, which to date has generally been accepted to be a kind of pure electrophysiological component. Although the other time we see ER a lot is in athletes, and it does seem to segregate with those athletes who develop structural remodeling. Although whether the two things are related causally or not, I think it's still up for a lot of debate. again, in terms, coming back to your point about the routine use of MRI in family members, again, I think it depends a little on availability. Echo is generally more available and cheaper than cardiac MRI. And in most cases where your index of suspicion is low to start with, I would imagine an echocardiogram would suffice.
I think that's such a great point. Dr. Mellor, thank you so much for this presentation. It's such important work. I've also gone back and read your CircGen paper from 2017 from the Casper registry multiple times, because I think that the improvement in diagnosis with broad genetic testing is really attractive. And, I'm a cardiomyopathy specialist. And so of course, I'm wondering how many of the genetic diagnoses in PKP2 and DSP were actually missed in this cohort because of limited genetic testing in patients who otherwise had idiopathic sort of VF, where cardiomyopathy might be concealed. What are your thoughts on that?
Yes, I think that's exactly right. So we had 2 of our probands with positive genetic tests. One was the DPP6 individual I mentioned. The other was a patient I look after in Cambridge who had apparently idiopathic VF, occurred at rest, and had a truncating PKP2 mutation identified, in fact, several years after his index arrest. We brought him back and we repeated his phenotyping. And he has a few ectopics on a treadmill test, but apart from that, no other sign of arrhythmogenic cardiomyopathy. Although unfortunately we can't MRI him now because of his non-conditional device. So I do think that if we had included genetic testing across the board, we would have found cardiomyopathy genes and indeed channelopathy genes in some of those idiopathic VF patients. So I would probably want to add genetic testing into our list of investigations for our proband. And I think if you've got a negative genetic panel, and you could argue a lot about which genes you should include, but if you've got a negative genetic panel containing major cardiomyopathy and channelopathy genes on top of those negative associations, then I think we can be very reassured that we don't need to go and bother family members so much.
Mm. You mean for genetic testing, you would still screen family members, you think, or you think that?
No, so I mean, specifically genetic testing of the survivor. So a negative panel in association with negative clinical test in the survivor means that you can be very confident that you're much less likely to find something in the family members. And if you look at our data, you could almost argue that in that combination, you don't need to test family members at all.
Right.
You both make an interesting point, and I think a very important clinical point. As a clinical electrophysiologist, I feel my approach to genetic testing is oftentimes guided by the ESC recommendations from 2015, where it's clinical phenotyping that should guide genetic testing. Obviously, your data would suggest otherwise, and I appreciate your input on this. Do you think the ESC guidelines or these should be changed? Yeah.
I think they will change, and in fact, I think the 2020 joint guidelines between HRS, APHRS, and ERA on sudden death evaluation of family members does include phenotype negative genetic testing as a 2B indication. So they were just published late last year, and I think we will see more and more data supporting this idea that you can have concealed genetic forms where the cardiac arrest is the first presentation. We see that also in the field of molecular autopsy. So these are sudden unexplained deaths, often with a normal post-mortem examination, but where post-mortem genetic testing will identify often a cardiomyopathy gene. Then
Would you?
Sorry,
Would you perhaps recommend that after a negative genetic screen for the pure arrhythmia syndromes, that then a targeted list of cardiomyopathy genes be used as a second tier?
Yeah, so that would be one way to do it. From a kind of pragmatic point of view, I guess all your sequencing is going to be done up front in one go. But then in terms of, you could have a tiered approach to which genes you analyze. That may reduce your risk of getting variants of uncertain significance, which in our Casper analysis, we found a very high burden of, and cause headaches for both the physician and the family.
Dr. Mellor, again, thank you for the paper. I found it very, very interesting from a clinical perspective because we are faced with these patients sometimes. Of course, I see them fairly late when they come to the EP lab for ablation. And in that sense, I have a question for you. The 4 families, I believe, that you described, none of those, the proband had PVC-induced VF, right? So I was wondering whether you found a difference between patients that present with short couple PVCs, Purkinje related, that triggers VF, as opposed to the one that goes straight to VF, like for early polarization or Brugada syndrome type of thing.
Yeah, excellent point. We didn't find a particular difference. I think the issue with short coupled VF is that it's often a diagnosis made on the second event. In my experience, it's once the patient's got an ICD and you have that tracing of the initiation that you can confidently say it's short coupled VF. Most of our patients were presenting for the first time, and obviously in that situation they're found in ventricular fibrillation. So knowing the etiology or the initiation of the arrhythmia is impossible. We didn't see any ambient short couple PVCs in any of our patients, suggesting that might be the diagnosis. So I can't comment on whether your yield of genetic testing is higher or lower in that group, so I don't think we had enough of each group to differentiate.
You know,
a question just for the panel quickly. How do you, so this was an interesting paper, we all agree with that. And how do you incorporate these findings, clinical practice? I mean, the yield was fairly low. So that would suggest that probably we shouldn't screen the families of patients with idiopathic VF. So I wanna understand how you would incorporate these findings in your practice. And then of course, Dr. Mellor, if you can after, how you incorporate your findings in your own practice. So.
I personally, oh, sorry.
No, please.
I personally find this extremely reassuring because I think when we have these patients who are young and we have idiopathic VF, we worry a lot about, of course, them, but also their family members. I do think that especially because of the reduced sort of MRI data, I do think that I would still want to do sort of at least a one-time screening in those family members, but it makes me feel a lot better about, what we had been doing every 3 years, et cetera, really reducing the burden of that cost for those family members going forward after that initial screening.
Yeah, I think one of the points also is there was a variable number of genes that were looked at in this cohort. And the question is, would the overall yield increase were more comprehensive gene panels universally done? So our practice is to do the 200 plus gene panel from the get-go. And if the initial sort of screen in terms of analysis of genes does not yield anything interesting, then we sort of proceed with the rest of the panel. So I think there might be an increased yield, obviously hypothetical, but I agree that I'm, first of all, reassured because this is so stressful when you have a scenario like this with a young person who had a sudden cardiac arrest event, whether they survive and even more so if they don't, which was another question that I was going to ask and get to in a moment in terms of the practical nature of this investigation. But it is a little bit reassuring that we can dig a lot and maybe not find a whole lot. So it takes a little bit of the pressure off, I guess, that sort of the genetics and our understanding sort of hasn't gotten to the point where, oh, you're going to miss something if you don't do this. That at the moment seems like it's at the low end of the spectrum. Nonetheless, I think even if you have a small yield, you have to obviously weigh the costs to the family, et cetera, in here. But I think even if you find a very small percentage of family members of probands and then family members who carry a particular gene, it's really helpful, I think, to know that up front. So I don't think that this will necessarily dissuade me from doing the full panel in the proband. And if we find something useful, then going along and checking family members as well.
So I would completely agree with that genetic testing in your affected individual, in your survivor, is going to be very important. And if you find something that then can be used for cascade testing in family members, then of course that should be done. In terms of how this has kind of influenced my personal practice, if you like, or my approach to it, is it reinforces the fact that we really need to focus our investigations on the survivor. I think if you look at, for example, that data from Paris and anecdotal historical data, people were labeled with idiopathic VF after maybe just an echocardiogram and an angiogram. And if you call that idiopathic VF and then don't screen the family, then you are going to miss a lot of important diagnoses. What I took from this is that if you really drill down on your affected individual, your cardiac arrest survivor, and you really don't find anything, and I would include genetic testing in that, then I think you can reassure the family members. Now, there's a lot of kind of psychological considerations going into this around family members as well, and I certainly would never deny anybody the opportunity to be screened should they wish. But I do think it takes, as a couple of people have said, takes the pressure and the anxiety out of it for family members.
Dr. Mellor, do you think that with that in mind, with what you just said, do you think, do you have any data or do you have any thoughts about longitudinal family screening? Obviously, we would screen longitudinally the proband if the initial workup comes back negative. That's an individual who's likely to get an ICD, and we'll continue to follow closely with the care team. But what about family members? Any comment?
So, I mean, we don't have the data from this study to answer that question. And potentially, if you continue to follow people, your yield is going to go up. I guess there's a balance between how often you test, the cost, the inconvenience, and I think the other thing that can sometimes be overlooked is that ongoing concern for the screened individual that there might be a problem. Every time they're brought back or told that that they're not discharged from the clinic, it creates an element of doubt. And it would be nice in an ideal situation to say, you've had your test and you're off the hook, as we can do in cases where we have a positive genetic test and then a negative relative. In our practice in the NHS, with budget constraints and resource things, and we don't routinely screen repeatedly in these situations if there's a negative assessment on the first time. But I don't have any data to back that up. But I certainly would agree with you that the individual themselves does require clinical follow-up and repeat assessment.
Well, one point though that Betsy brought up in the beginning was that in patients with adrenaline testing, and then you talked about this as well, Dr. Mellor, that there may be quite a few positives within that population, and unfortunately, many of them are going to be false positives. However, in a first-degree relative of someone with idiopathic VF or putatively idiopathic VF, if you were to follow that person over time, there is a chance that they might have another risk factor found later on, like perhaps they have unexplained syncope, in which case, if that person has a first-degree relative who's had idiopathic VF and they had a positive adrenaline challenge, and now they have syncope, well, you might think about an ICD in that person. Can you comment about that?
Yeah, so I can certainly envisage that situation just as you've described. I think that would probably be at this point a research question rather than going straight to recommending sodium channel blocker provocation in all family members. And if maybe you had a study set up a little bit like ours where you mandated that everybody had sodium channel blocker provocation, and then you had a sufficient follow-up period to see whether that made a difference, then I think then you would have the data. Unfortunately, that's going to be a difficult study to do. You're going to need a lot of families probably to get enough events to know whether you've done the right thing or not. But it's certainly one of the interesting areas is this apparent higher pickup rates in these family members, similar to what we see in family members of sudden unexplained death victims who haven't survived and where you can't phenotype the individual. We know that adrenaline testing can be positive in around 20 to 30% of those families, and that's been shown, in a couple of studies. But the event rates in those adrenaline positive individuals are still low. So I personally do worry about labeling people on the basis of adrenaline testing, and we counsel our patients quite heavily before they agree to an adrenaline test in terms of asymptomatic relatives. I think it's different when you're talking about somebody who's already had a cardiac arrest. The downside to an adrenaline test, the risk of false positives are less important for that person.
There was a question, it looks like, from one of the attendees, Leora Yankelson, who asked, given the modest benefit of genetic testing in idiopathic VF, is it important to focus on highly important findings such as PVCs, such as their morphology and coupling interval? And I guess to add to that question, is long-term cardiac monitoring, like an implantable loop recorder, of utility in this type of patient where all testing, including genetic testing, perhaps has not yielded an answer? I know that's a little bit beyond the scope, but it's an important question clinically.
Yeah, so again, I think this chimes in with what we've been saying, that you should be as exhaustive as possible in your clinical assessment of your survivor. Fortunately, the kind of telemetry capabilities of most ICDs now, particularly transvenous ICDs, means that you do get a lot of information, maybe not PVC counts and coupling intervals, but you do get a lot of information in the long run. And you may be able to make a diagnosis, particularly thinking about short coupled VF, on the back of those ICD recordings. The other thing to talk about PVCs is yes, it is important to look at their morphology and their coupling interval, not particularly for IVF, but maybe actually you're going to be pointed more towards an arrhythmogenic cardiomyopathy, which has very little effect on LV function. So something like a DSP cardiomyopathy, where the MRI findings can be quite subtle, and the ambient PVCs are an important part of the diagnosis and look very different from those His-Purkinje short coupled VF PVCs.
I'd like to ask the panel, I'm sorry.
No, please.
There's a question that veers a little bit off topic, but you were beginning to talk about long-term follow-up of family members and how that has negatives as well as positives. And I think in this situation where you have a surviving proband and you're able to do such an exhaustive evaluation, as we've said, it's somewhat reassuring that the family members can probably feel fairly low risk. What is your practice, however, when the proband died suddenly and you don't have the ability to do such an exhaustive evaluation? Then it's well articulated what we should do to evaluate their first degree relatives and so forth. But what about the long-term follow-up of those relatives? It's hard to keep them coming back.
Yeah, indeed. So our in terms of the first three relatives of a sudden unexplained death, we would initially investigate them much in the way that we do the cardiac arrest survivors. As I've mentioned, there is a little bit of a conversation around adrenaline testing, which we reserve till the other investigations are negative. But we do offer adrenaline testing for patients of sudden unexplained death victims, and as been shown in previous studies, it's positive in a good number of families. In terms of the longitudinal follow-up, if we have an adult who has a completely negative initial assessment, and we are very confident that, or as confident as we can be, that the victim had a normal heart, and particularly if we're able to have done a molecular autopsy, which is becoming more frequent, we don't routinely bring them back for serial evaluation. It's a bit different when the relatives are children, and obviously you think that there may be age-related penetrance coming through. But if they're beyond the age of, say, 25 and completely well, we don't routinely bring them back. But we always tell our patients that they're welcome to get in touch should they have any concerning symptoms, particularly syncoping. But really any concern, and we'll run them back through the same sort of assessment again.
I wanted to extend that question further to get back to a topic I alluded to earlier, which is that obviously it's such a challenging scenario. If the proband did not survive, how do you manage the relatives? But the question is, to what extent can we do a molecular autopsy? And this gets into education of the physicians who managed family members or who had taken care of the proband if they had sought medical care before, which often is not the case. I do know that at least some medical examiners, for example, will save a blood spot card if a lot of these deaths occur out of hospital and are sudden, and the medical examiner may or may not choose to take the case on as an autopsy or dismiss it as clearly from natural causes and not investigate. But the point is, I think there is an opportunity that could be increased if we educate medical examiners and family members, et cetera, when these things happen. If we can catch the scenario real time, obviously if it's in the past, it's in the past, but we can catch it real time. So-and-so just had a tragic sudden death, a family member, and they did not survive. In terms of what instructions physicians should give to the medical examiner in terms of the type of tissue to save, the quality of the DNA in that tissue, and then of course the expense and how you even orchestrate a post-mortem examination. And obviously it's a very complicated series of questions that I've had to tackle a number of times.
Yeah, so it's, as you say, it's a really difficult area. We know the science behind molecular autopsy makes sense, and we would like to do molecular autopsy on almost all sudden unexplained deaths, particularly with a normal post-mortem. And the solutions to accessing DNA, which I think is the main barrier, it's getting hold of that DNA, as you said, in an appropriate time, will be different depending on which part of the world you work in and what your legal kind of framework is. In the UK, we have the coronial system, which is essentially run by lawyers, and where there is a mandate to investigate any sudden unexplained death, often with a low threshold for a post-mortem exam. But the focus of that is to ascertain as to whether there's been any foul play, any legal implications. And once the coroner has satisfied that the death is natural, then their motivation to go on and do further testing, such as a specialist cardiac post-mortem, such as retention of DNA, is lost. We're working in the UK on a framework where we can try and, as you say, educate, work with our coroners and with our pathologists so that people are more aware of the need to retain tissue. We're recommending either whole blood or spleen at the time of post-mortem, working with families so that we can get the permission, the consent to retain that tissue, and then get it to the genetics lab, extract the DNA, and potentially return that tissue in a timely manner. So these are all big challenges, and they're all logistical challenges rather than medical ones. But I think they are kind of fights worth having, if you like, and the benefits for families in the long run of molecular autopsy, although the yield again is relatively low, I think it's an important part of our armory in terms of preventing further sudden deaths.
You mentioned in the paper, by the way, the fact that this is a bit of a selected population, meaning those who survived their cardiac arrest. And I believe you hypothesized that if we were to do a molecular autopsy in 100% of patients who did not survive, then certainly you would siphon off a number of those. Had you had the ability to do clinical testing, you'd find that some of them had, overt phenotypes, if you will, the Brugada and long QT and other such things. And so of those who did not pass, there would be a certain group of them who would have fallen into the category that would have been excluded in this study. And then the rest of them might have had a similar yield to this population that you ended up studying. Do you think did I state that accurately, or do you think that patients who die might be a different group?
I mean, yes, what you said is accurate. What we were trying to do is trying to compare the yield of family screening in different groups. So in those where the cardiac arrest individual didn't survive, to those where a particular diagnosis was made. And the idea being, yes, a proportion of those sudden unexplained deaths, if they had survived, would have a clear phenotype you would pick up on their ECG that otherwise is not available. And so in that group, the yield of genetic testing, say, for example, in your long QTs, is pushing 70 to 80%. So that will enrich your overall yield. Whereas we had a group where we tried to actively exclude that, and therefore would kind of push the yield down
Yeah, so that actually argues more in favor of pushing for postmortem genetic testing.
Yeah.
In fact, that population includes a lot of people who have an overt phenotype, but you didn't have the opportunity, and therefore you might have a much higher yield of genetic testing.
Yeah, and I think if you were able to compare a molecular autopsy series with a cohort like ours who all had standardized genetic testing, you would find that the molecular autopsy rates were slightly higher because of exactly what we just discussed.
I think it's impressive, your paper from the Casper registry in 2017, the genetic diagnostic yield of a broad panel, I think was something like 21%, which is almost on par with what the Undiagnosed Disease Network is getting for, folks with whole genomes. And so I think it's actually a big argument for doing the molecular autopsy in these patients.
Yeah, and again, in these idiopathic VFs, because of the way that Casper is structured, not all patients had exactly the same investigations. I don't think we'd get quite that same yield, and other series haven't shown quite as high. But I certainly think 5 to 10% would be the minimum you would expect to get from idiopathic VF genetic screening and then molecular autopsy. I think the kind of landmark Australia and New Zealand paper was around 17 to 20%, I think. So yeah, it's an important tool, and when you have that genetic diagnosis, then your family screening becomes a lot easier, because you can reassure those gene negative relatives that they don't need clinical screening, they don't need a lifetime of surveillance, which, as we've discussed, can be troubling. And you can also focus your clinical assessment around the expected phenotype that your variant would be expected to lead to.
Greg, one finding that I found quite interesting is that if you look at the family history of sudden death in the, actually I'm looking now table 1, actually was more prevalent in patients with a negative family screening. It was 13%, and none of the patients with a positive family screening had a family history of sudden death.
Yeah.
Do you treat these patients differently? In other words, even if a negative family screening, do you still follow them to understand maybe they may have some other manifestations that were not captured in your screening for some reason?
I think it depends on a little bit of the detail of what that other family history of sudden death is. In this study, I can't remember the exact wording we used, but it was if there had been any other first-degree relative who had died suddenly. We didn't put an age cutoff on that. We didn't kind of stipulate whether that patient had pre-existing diagnoses. So some of those sudden deaths may have been in older individuals with coronary artery disease. And I think if you heard that history, you wouldn't particularly do anything different. But if you had a family member where there had been multiple sudden deaths, particularly at a young age or in suspicious circumstances, then that may push you towards either more in-depth assessment or more regular assessment of those individuals. But I don't think we quite had the granularity in this paper. And again, because of the small numbers, although, as you said, it's 13% versus 0, the p-value still comes out at 0.4. So it's it's not a big enough cohort to comment on that.
I just to follow up on Pasquale's point, I felt the same thing about history of syncope. The negative family screening, there were 17% that 17% were the history of syncope that mirrored the burden of syncope in those in the proband population as well. And I just wonder whether you would, your gut, at least my gut clinically, would be for more extensive phenotype screening in those family members.
Yeah, so the reason we included those two factors is in that Casper genetics paper, both a history of prior syncope and a history of family sudden death increased the yield of genetic testing in the proband themselves. And so by extrapolating, we kind of were hypothesizing that they are markers of a genetic condition in the family, although they're quite soft and they are subjective in their recording. But yes, I think if you had if your family member comes forward for screening and they have concerning symptoms, you're going to treat those people slightly differently to those who are completely well.
Right.
Does that answer? Is that?
Yeah, it does. I mean, right, those are people where you may even evoke EP study, right?
Yeah, yeah. And similarly, if someone's had a family member's had a negative assessment, as I mentioned earlier, and then gets back in contact saying they've had a change in their clinical status, particularly syncope, then we would reassess them. The role of EP studies in idiopathic VF, again, it's been looked at. There's an ongoing study run by Jason Roberts, looking at the yield of EP testing in cardiac arrest survivors. And this is driven by a few case reports of bundle branch re-entry VT and some SVTs that have gone on to cause hemodynamic compromise. So we'll wait to hear what that study shows, but I don't think the yield of kind of traditional 4-wire diagnostic EP study is going to be particularly high in those survivors.
Have you thought about planning your next step with the early repolarization phenotype survivors?
Not particularly. I mean, early repolarization, I feel, is it's such a difficult phenotype to grips with. I think some of what we call early repolarization is something completely different. Maybe as was mentioned earlier, some fractionated conduction rather than true early repolarization. I think within early repolarization there are different subtypes. Some of the early papers from Finland split the categories by ST segment gradient and found that the ACE in the ST segment gradient had a benign prognosis, whereas the horizontal ST segment had a worse prognosis. But again, reliably putting people in one cohort, in one camp rather than the other, is difficult. ER can change with heart rates, with levels of exercise. It changes over time. There are so many things that make it a difficult thing to address. I think Andrew Cryan once described it as being like a Hollywood sequel to Brugada syndrome. It's kind of bigger and it's more popular, but in the end, it doesn't really make any sense. And I think that's kind of how I feel about early repol.
One quick question. I don't know, and this is probably, infinitely more complex, but, and I don't know when, if ever, we'll get to this point, but the interplay between genes obviously is sort of the holy grail of figuring out some of these patients who are, quote, gene negative or just have undetermined genetic mutations. And the question is there going to be any way that we can, in the future, figure out that there are sort of high risk combinations of mutations? And I think that we're struggling enough with single gene mutations as it is, so that's probably kind of a pipe dream thought for a long time. But maybe as the registries increase in numbers, and by the way, a whole other direction of question is minorities. I mean, that's a huge elephant in the room here, is the population of patients in this study does not include many minority patients, which we're hoping in our, for example, our Temple population, where we have a much bigger minority community, that maybe we'll be able to add to the clinical database information. But is that wishful thinking that in the future, with greater numbers, we'll be able to start looking at gene interactions?
I'd hope so. I mean, if you look at the Brugada genetics literature, we're certainly looking at oligogenic inheritance, and there have been small polygenic risk scores put forward for Brugada syndrome, and also the response to sodium channel blocker provocation. So I think that is an achievable goal, although, as you said, it's going to be extremely complex. But the answer to it is going to be larger registries, as you say, of more well-phenotyped patients. Then come on to your second comment. I absolutely agree that one of the limitations of this study is that the vast majority of these patients came from Northern European families. There wasn't a wide variety in ethnicities, and therefore, you have to be careful extrapolating these findings to other groups where genetic variation is going to be different.
Yeah, and vice versa as follow-up. If you had a patient belonging to a minority population and you're really comparing their gene and looking for less than 1% incidence in a reference database that does not represent that demographic group very well, really, what are we doing in that scenario? I mean, it's really going to be misleading in terms of the conclusions that one might draw from that comparison.
Yeah, I mean, absolutely. I'm not a geneticist, but yeah, I would agree that you have to be checking your patient against a reference that is
Comparable, yeah.
Yeah, exactly, comparable to their ethnic background.
Which doesn't exist for most demographic groups around the world, to be honest.
And you hope with more widespread genetic testing, costs coming down, larger registries, larger data sets, that things like Nomad will help with that. But it's a kind of slow, step-by-step progress, but very extremely important, definitely.
Okay, I think we're getting close actually to the end. If you have any other question from the panel, feel free to ask. Otherwise, okay, I don't think there are any more questions. And Dr. Mellor, really, we do appreciate your, first of all, your very, very good paper and staying so late with us for the webinar. Thank you, we appreciate it. And thank you, Dr. Cooper, Dr. Parikh, and Dr. Deo for being part of the panel. Dr. Kaufman, of course, my co-moderator, and Dr. Morin, Dr. Wang for this opportunity. Good night, everybody, and see you next month for the next webinar.
Thank you, everyone.
Thank you all.
Thank you. Bye-bye.
Yeah.